Our next scholar is Morgan Staver. Morgan is from the University of Nebraska Medical Center. Her hometown is Clive, Iowa. It's a little closer than Bangladesh, just across the border from Nebraska. Her faculty mentors are Dr. Kathleen Hanna and Dr. Tiffany Moore. Her project will examine the maternal distress, such as depression, anxiety, and trauma, in mothers of infants in the neonatal intensive care unit. Morgan, it's all yours.
Thank you. Give me a moment to share my slides. All right, and are you seeing my screen and not my notes? Awesome. Okay, well, first I just wanted to say thank you for this opportunity, not only to complete this research, but to present the findings here today. My study that I'll present today is titled A Mixed Methods Examination of Maternal Distress in the NICU. And then my committee advisors were Dr. Hanna and Dr. Moore, as Dr. Welsh just introduced, and then my other committee members were Dr. Hanisch, Dr. Matthews, and Dr. Needleman. So the purpose of this study was to investigate the perception and experience of distress in mothers of infants born after 34 weeks of gestation in the NICU. And this population was identified by previous work doing an integrative literature review, in which I found that most work in this area is done on more premature infants who are born at lower birth weights, even though that this population of infants born after 34 weeks of gestation constitutes the majority of the NICU population. The specific aims of this study were to determine the incidence of and relationship between perceived symptoms of distress, to compare distress symptoms in mothers who are currently in the NICU with mothers of infants who have been discharged from the NICU. And that first aim is a quantitative aim. The second aim was to describe perceptions of maternal psychological experiences of the infant's hospitalization in the NICU, which was a qualitative aim. And the third aim was to describe the extent of convergence or divergence between quantitative measures of current distress symptoms and qualitative descriptions of psychological experiences while the mother was in the NICU with her infant. The concept of maternal distress in the NICU is shown here, and this was used to guide the study. So maternal distress in the NICU is the combination of symptoms of depression, anxiety, and trauma experiences that occur on a spectrum of severity from mild to severe. The EPDS, or the Edinburgh Postnatal Depression Scale, was used to measure depressive symptoms. The State Trait Anxiety Inventory was used to measure anxiety symptoms. And the Perinatal Post-Traumatic Stress Disorder Questionnaire, or the PPQ, was used to measure trauma experiences. So this study used a pragmatic lens to inform the Convergent mixed methods design. And a Convergent mixed methods design uses parallel qualitative and quantitative arms that are conducted at the same time but kept separate. The results are analyzed separately and then integrated to provide greater insight into the concept than would be available with either a qualitative or quantitative study alone. So first, the participants completed a demographic questionnaire, and then instruments measuring attributes of maternal distress in the NICU, those scales that I described on the previous slide. And then after the quantitative data was collected, all participants were asked to complete one semi-structured interview via Zoom. So I conducted a power analysis to determine the study's sample size, which ended up being 21 participants. And these participants were taken via convenience sample. I had originally recruited participants from Children's Hospital and Medical Center NICU, but after some slow recruitment processes, I ended up moving the recruitment strategy to social media. So I targeted NICU-focused groups of former and current NICU mothers to disseminate my research flyer, which is shown here on the right. I analyzed the quantitative data using SPSS, and so I calculated descriptive statistics, correlation coefficients, prevalence estimates, and did non-parametric tests like the Mann-Whitney and Kruskal-Wallis tests. I analyzed the qualitative data in MaxQDA. I recorded the interviews and they were transcribed verbatim. I analyzed the transcripts using directed content analysis, which is a method that uses predetermined codes to analyze the transcripts, and this was guided by the maternal distress in the NICU concept. The mixed methods analysis was done in SPSS, MaxQDA, and Microsoft Excel, and this analysis was guided by Cresswell and Plano-Clark. The quantitative data were reduced to descriptive statistics and prevalence estimates, and the qualitative data were reduced to summaries of the codes. This data was then displayed in tables, transformed, correlated, and integrated. So these are the characteristics of my sample. And I have some interesting characteristics in red. So this group had a fairly prevalent mental health history of self-reported diagnoses of depression, anxiety, and PTSD. The sample was also well educated, with all participants having at least some college education. The sample was 95% white. And not shown on this table, but also notable, is that all participants were in a long-term committed relationship with the infant's father at the time of data collection. Most infants were admitted for prematurity only. Other reasons for admission were respiratory distress, surgical needs, and then one infant was classified in the other category. So for the results of my first aim, which was the quantitative aim, I found that 43% of participants scored positively on the depressive symptom scale, which was indicated by a score of greater than 10 on that EPDS measure. 19% scored positively on the state anxiety measure, indicated by a score of greater than 40 on the state scale of the STAI. And finally, 71% of participants scored positively on the PTSD symptom scale, which was indicated by a score of more than 19 on the PPQ. The distress attributes were related in the sample, which is consistent with previous work. 76% of participants scored positively on more than one distress measure, and 19% scored positively on all 3 distress measures. Also consistent with previous work was that the symptoms of depression, anxiety, and PTSD were highly correlated, with the lowest correlation coefficient being 0.503, and the correlations between all 3 symptom attributes were statistically significant. For my aim 1 part B, which was to compare the groups of mothers of infants who were currently in the NICU versus those who were discharged, I was not able to find a statistical difference between those 2 groups, but this was likely due to the small and uneven group sizes. So I had 3 participants whose infants were currently in the NICU at the time of data collection, and the majority of those were discharged from the NICU, the majority of the participants, 18. And this was due to the recruitment struggles that I had alluded to earlier. All participants, though, were within the 2-year time frame of the NICU stay for my inclusion criteria. So my second aim was the qualitative aim. Mothers often described their psychological experiences in the NICU as distressful, describing experiences with frustration, uncertainty, feeling overwhelmed, hypervigilance, loss of control, guilt, catastrophic thinking, sadness, and worry. This distress decreased over time, and the distress did not always overwhelm the mother's ability to cope. And when the distress codes were summarized and categorized, 2 major themes with 2 sub-themes each emerged, which were changing perspective, with seeing as believing, and the maternal identity as sub-themes, and past and future loss, with stolen joy and worst-case scenarios as sub-themes. In the changing perspectives theme, I found that although the reality of the infant situation did not change based on the mother's setting, the perception of the infant's status and the mother's distress changed based on the context. Time, distance, and the ability to provide hands-on care influenced the mother's perception and expression of distress while in the NICU. And the development of a maternal identity was unstable while in the NICU, and it was influenced by relationships with older children. In the past and future loss theme, there was an overwhelming sense of loss and uncertainty that characterized the NICU stay. Mothers really mourned for their lost experiences that they were expecting in that early postpartum period, and they were watchful for any indication of potential future losses due to the loss that they had already experienced in the worst case scenario of that NICU hospitalization. The mixed methods analyses showed that the quantitative and qualitative findings were mixed regarding depressive symptoms. Findings were consistent between the two types of data when comparing descriptions of depressive symptoms with the frequencies captured in the quantitative measurement. The most frequently described and reported symptoms of depression in the two types of data were sadness, crying, and low self-esteem. However, the quantitative and qualitative findings were divergent when comparing descriptions of depression between participants with negative and positive depression symptom scale scores. So one example of this is that those with a negative depression symptom scale score were more likely to describe feelings of sadness and crying in the NICU than those with a positive score. So next, with anxiety symptoms, none of the participants scored positively on the STAIS that participated in the qualitative study. However, descriptions of worry and catastrophic thinking that had an impact on daily life were common in the qualitative findings. And I just wanted to put a note here that of the 21 participants, 14 of them completed both the quantitative and qualitative arms, and the ones that didn't complete the qualitative interview were lost to contact, although I did achieve informational saturation with the 14 participants. And then finally, with the mixed methods, the findings were convergent regarding trauma experiences. Lost my mouse. And so digging into that a little bit deeper, this graph shows the PTSD symptom score on the y-axis, which was the quantitative measure, grouped by the qualitative endorsement of exposure to a traumatic event on the x-axis. So as you can see, those who described a traumatic event in the NICU during the qualitative interview had higher average scores on the quantitative PTSD symptom scale than those who did not endorse an exposure to a traumatic event. Similarly, those who described symptoms of re-experiencing in their interview, including experiences like being reminded of the NICU alarms when they heard their microwave beep at home, for example, they had higher PTSD symptom scores than those who did not describe those re-experiencing symptoms in their interview. So some unexpected findings that came out during this study. So this dissertation study really showed that the prevalence of depressive and anxious symptoms are more similar to previous work with this population than the PTSD symptoms were. In a previous study that included only moderate and late preterm infants, so those excluded term infants, unlike my study, PTSD symptoms were present in approximately 15% of the sample, as opposed to 71% of the sample in my study. But one major difference between the two studies was that in the studies, the mothers did not know of the need for a NICU hospitalization before birth, which was part of the inclusion and exclusion criteria. And so this may have led to feeling more out of control in the NICU setting than mothers in the previous study. Another unexpected finding was a specific convergence and divergence between depressive, anxious, and traumatic stress symptom assessments. So this study is really the first mixed methods study in this conceptual area with this population. And so beginning the mixed methods analysis, I really wasn't sure what to expect when first analyzing this data. So we were asked to present on our next career steps. So as far as my next career steps go, I'm currently interviewing at a few companies as a scientific researcher and writer. And I plan to focus on projects that continue in this line of work of women's health and child development research. And then in addition to my PhD, I will also graduate with a postgraduate certificate as a psychiatric mental health practitioner, completing both of those programs here in 2 weeks or so. So I plan to take boards for that certification this summer And then I'm keeping some options open to enter into clinical practice later on in my career as a nurse practitioner. So again, I just want to thank the Buffett Institute for this incredible opportunity to complete this research. So thank you all for listening.